So thinking about locally advanced gastric cancer, thinking about potential surgery options, I get so many questions. How do you treat an esophageal patient versus a GE junctional patient versus a gastric cancer patient? Should I be giving chemotherapy? Should I be giving chemoradiotherapy? Should it be neoadjuvant? Should it be adjuvant? How do we make sense of all this? David, can you start us off by thinking about what your approach is?
Yeah, well, I think the take-home message is that adjuvant or neoadjuvant treatment improves outcome. So we know that surgery alone for T3 or node-positive disease is no longer acceptable. And I think systemic therapy plays a role in all of these diseases. And the issue is what's the contribution of radiation therapy? I think for tumors of the esophagus and the more proximal GE junction, we have anatomic considerations. We know historically, and even from data from randomized trials, that patients that undergo surgery have fairly high rates of inability to operate. Curative resection rates in the 60% range. Even some contemporary surgical arms in British studies, 1,600 patients in two recent large British studies that reported R0 resection rates in the 60s. So to me, systemic therapy is clearly, chemotherapy is important. For tumors of the esophagus and GE junction, given the risk of inability to operate, and also fairly high rates of local recurrence, to me, those patients should get chemotherapy plus radiation. And the standard was really defined by the CROSS trial in the Netherlands, which gave a relatively simple chemotherapy regimen, weekly carboplatin, paclitaxel, and radiation, followed by surgery. This trial achieved R0 resection rates in the high 80s to 90% range, reduced local recurrence, and even a brief exposure to chemotherapy reduced metastatic disease and improved survival. So I think that for esophagus and the more proximal GE junction tumors, that's the approach we endorse in the US. In terms of neoadjuvant chemotherapy, that was really established as a standard of care in Britain. The MAGIC trial looking at perioperative ECF versus surgery alone improved survival. So that really became the standard in the UK and the West to give perioperative chemotherapy with ECF with surgery. But even that trial with chemotherapy alone, you didn't get enhanced rates of resection, and the role of radiation in the gastric cancers was not well defined. Recent studies have looked at whether adding radiation to perioperative chemotherapy improves outcomes. So the CRITICS trial, over 700 patients treated in the Netherlands and Sweden and Denmark, randomizing patients to perioperative chemotherapy alone, with or without the addition of radiation, showed no survival benefits. So for GE junction gastric cancers getting perioperative chemotherapy, adding radiation postoperatively did not show a benefit. Kohei can comment that you see mostly gastric cancers, and given the screening and potentially earlier stage, upfront surgery is the preferred approach, and adjuvant chemotherapy is the preferred approach in Japan.
Yeah. Actually, D2 gastrectomy is a standard procedure from, very old days, from the old days. So, but the surgical procedure is not changed. So they do a D3 gastrectomy, but did not improve outcome. So D2 is still standard.
This is actually very important because, way back when we looked at the intergroup 0116 study, we saw that the surgeries were very variable depending on the surgeon. And tell us a little bit about, especially with the Japanese experience between
Yeah, actually, it is very difficult to explain in one word. It was defined in the Japanese guideline because D2 gastrectomy is different in each region. If patient had a proximal tumors, this should be dissected lymph node. It's slightly different from the distant tumors. So this kind of lymph node should be removed is defined in the guideline. So overall, this is the D2 gastrectomy. But again, D3 gastrectomy and the splenectomy did not improve the outcome.